is that there are plenty of things that we can also learn about the system as a whole. And so to talk a little bit about how to talk with mental health providers, we've invited someone else who has been around with us since one of the beginning, 10 years of the community of practice. So Dr. Colleen Mortell.
Hello, my name is Colleen Mortell, and I am a psychologist and board-certified behavior analyst, and I'm one of these providers we've been talking about today, mental health providers. And my history is I've got a PhD in clinical psychology, and I wasn't really studying autism or developmental disability. And then I finished my postdoc and I needed a job. And I got a job at the Wisconsin Early Autism Project. And I was very fortunate because basically they trained me very well from the ground up. They had me work with a variety of people with autism, kids back then, 3 to 6-year-olds, as a direct service provider, and then as a senior therapist, and then as a lead therapist. So I had an opportunity to learn a lot about people with autism, but under a very supervised situation. And ever since then, I've gone back and forth between doing intensive, what we used to call ABA, treatment with people with autism, and then a more of a general mental health practice, still specializing in people with autism. And I don't know if I mentioned it, but I work at Psychiatric Services here in Madison, which is just down the hill from where we are. So the question is, why is there such a shortage of mental health providers who are knowledgeable about autism? I don't know. But I do think one reason is historical, and all the speakers today have been talking about how to pay for treatment if you have an autism diagnosis or you have a mental health diagnosis. And historically, 25 years ago when I was in grad school and dinosaurs roamed the earth, it wasn't the way it is now. Basically, at that point, if a person had a developmental disability diagnosis, it was very difficult to get insurance, for example, to cover their treatment for their major mental illness. So if I sent in a PA for someone who had an anxiety disorder and autism, the reaction was, well, autism is incurable, so no, So that's how it used to be. That never happens to me now. It just never happens. I've never had that problem. But I do think it takes a long time culturally to catch up, and so for mental health providers to come and specialize in autism, it's taken a long time, I think, for that. So what constitutes, autism-informed mental health treatment? Obviously you need education. You need an education background. And secondly, you need, I think, supervised training and clinical experience under supervision, as opposed to what happens sometimes where you're just, all of a sudden you have these people with developmental disabilities in your practice and you're winging it and figuring it out. You need years of clinical experience. For example, I get this question a lot. Someone will say, okay, so is this behavior autism or is this just rotten teenager? Well, you have to know a lot of people with autism and rotten teenagers to be able to answer that question. Lastly, I think the benefit you can offer is some knowledge about all the things that we've been talking about today, like who's available in your community that's good with autism, or what's Katie Beckett, So having enough of a knowledge about the general issues that you can be a useful resource. Okay, so that is what every one of us deserves and what we should have. We should all have someone with that level of expertise to treat our mental health or medical condition. But obviously, realistically, that isn't the case a lot. That's why we're all here. So when I thought about what to do with my 20 minutes, I thought maybe what might be helpful would be to talk to you about what I think about when I approach someone who has an autism spectrum disorder. And the idea behind it is that hopefully you can create a profile for yourself or for your child or for the consumer you support that would make it possible for you to communicate with a competent generalist in a lot of situations so they could be useful for your consumer. I'm thinking of situations like, corrections, where you might suddenly find your consumer in the correction system, or suddenly they're at the hospital for an emergency detention, or maybe they're at the hospital for a medical situation. In any one of those cases, there's going to be hopefully a competent generalist mental health provider there. So how can you communicate with them and hopefully make them competent to really help your consumer? And again, the real idea here is, how can we help the provider to adjust to the needs of the person with autism versus what happens so much is, the other way around. So this is kind of my list of what I think about whenever I'm treating a person on the spectrum. And kind of what I would ask you to think about as you introduce your consumer to your next clinician. So the first thing that comes to mind, of course, is language. The vast majority of people on the spectrum have some kind of language issue. If it's a really clear one, a competent clinician is going to understand that. But if it's more of a subtle language processing issue, they might not. So for me, when I'm meeting someone, I'm checking early and often if they're really understanding what I'm saying, if I'm really understanding what they're saying. So formally checking that and making sure that the communication's happening. Another thing that I'm sure you've all experienced, if you have a language processing issue, you're going to have trouble processing this quick language such as I'm giving you guys right now, where it's like sentence, 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 boom, 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 boom. If you're trying to process something from the first line, you're not going to get the whole long paragraph of communication. So I think in terms of, I think about what the point I want to make, how I can make it concisely. I make my point and then I stop. So if that's something your person would benefit from, that's the kind of summary you could give to your next provider. Next thing that I always think about is sensory needs. Is what the environment that you're going to meet this person, does it have a weird smell? Is it too hot? Is it loud? Is it too confined? Do they need to be able to move around? Obviously we all know that if those things aren't as they need to be, it's not going to be a successful interaction. So if you can kind of lay out what your person needs to succeed, then hopefully the provider can provide that. So speaking of functioning, I think the most important point is, what does this person need to function in this environment, in this particular mental health interaction? They will tell you. They will tell you what they need. And my policy is basically 100% responsiveness to what they say they need. So if a client comes in and says, it's hot in here, I say, it's hot in here? Should I open the window? Can I get a fan? Do you want to take your sweater off? But we don't go forward until we've taken care of the heat issue, because I think what they're really saying is, I can't function, it's hot in here, And people who are, neurotypical, usually they're like, well, it's hot, but I can do it. But I think usually when people on the spectrum voice a complaint, really what they're saying is, I can't succeed unless we resolve this. So, and sometimes we can't resolve it, but at least we stop and try. The next point I think is important is, people on the spectrum are more often making a decision based on their personal experience, as opposed to, I think, a benefit of being neurotypical is you often learn a lot from other people's experiences, so your decision making is more broad and shared. If you don't understand that, then I think sometimes the decisions they're making will seem wrong or illogical from the neurotypical point of view. But of course, people don't make bad decisions, right? They don't make a decision that's going to shoot them in the foot deliberately. So, and they, my clients often say, I am 100% logical, or I always make good decisions. And they are. And you have to understand that you're coming from two different points of view. So what example that came to mind for me with this one was, like when I was in middle school, I had older siblings, and they were all getting jobs. And I would watch them, and I'd notice, well, one of them detasseled corn, and one of them worked at the ski place. And I was like, well, what's a good job? And I was always gathering information from the world about what would be a good job. And I would ask my friends. And maybe even someone had a parent who had a business who could hire me. So that was how I chose my, high school job. And so someone on the spectrum, they don't usually gather information that way, right? They're more based on their own experience. And a conversation I had with one adult about this, it was time for him to get a job, and his parents, I could tell, were really fed up with the speed this was progressing. And they'd had it, which I could tell. And his process is he would search the internet, he'd find the right job, and he would apply for that job. And then 2 weeks would go by, and he hadn't heard, And I'm saying, maybe apply for 4 jobs. But, from his point of view, why would you do that? You'd already chosen the best job. So I think if you understand that part as a clinician, you're not going to keep kind of arguing this point of view, but you can kind of accept their point of view and go from there. The next one is supportive psychotherapy isn't necessarily supportive. So again, neurotypical people often come to psychotherapy for the experience of sharing what happened, a compassionate listener, and they'll say, okay, I don't know what to do, but I feel better because we talked about it. That's not necessarily going to be true for people on the spectrum. The relationship is still the foundation of any successful mental health encounter, in my opinion, whether it's a med check or psychotherapy or whatever. But you have to build the relationship differently. So, when I go out to the lobby to get my client, I'm excited to see them because I like them, and my face lights up, and they just look at me like this. Because my mere presence isn't exciting to them. However, once we get in there and we start talking about the things that they like and we do what we do, then they're going to enjoy it. This can come as a shock to people whose basically clinical approach is to be, warm and supportive. So another good question to ask is, if you yourself are the consumer or if you're representing someone is, what is your intellectual profile? Do you need to have some adjustments for that? So, if you have a neuropsych report, go ahead and send it. Send it to them early or bring it. If you have an M team that you can report, that you can show them, then they'll have a basis for what they're doing. Because again, especially with autism where there's splinter skills, superficially you can have a kind of a false impression of the person, and that can cause problems. So a mistake I've made several times, enough that I remember, is a client will ask me to write something down for them. I'll write it down, I'll give it to them, and they'll say, I can't read cursive. And I'm like, yeah. That's not good. I don't want to do that to people. So if you can load the person in advance with information about that, it's very helpful to them. Related is attention issues. Most people on the spectrum have issues with attention. So then what that means is that the clinician has to adjust my agenda to suit their attention. So this just happened to me yesterday, so it's fresh in my mind. I gave a young adult client one of those rating scales that we use, we use depression rating scales. This was an anxiety rating scale. So he did 2 or maybe 3. He put down his pen and he said to me, who's your favorite Muppet? And I said, well, let's wait to talk about the Muppets. We'll talk about it later, but let's wait. And then he did like a few more, and then he looked at me again and he said, there are 20 of these. And I said, yeah, that's a lot. And he said, what if I did 10? I said, okay. And then he said, next time I come, what if I do the other 10? I said, that's great. Perfect. So, you know, he knew, and he can advocate very well, and that worked out beautifully for us. But we have to know in advance a bit what kind of attention issues there might be. Help your clinician to anticipate and prevent behavior issues. Right. So if there's something that's going to trigger this person or cause them to have upset or behavior, if you can tell the clinician, they of course want to cooperate with that. If there's going to be, you know, if a person is likely to be aggressive, that's good to know. But are they likely to be dangerous? That's very different. You know, if a person is doing something, breaking things or yelling, but if that's as far as it's going to go, that's very different than if there's going to be dangerousness. Another thing that happens a lot is like threats of self-harm. So some of my clients threaten self-harm quite a bit. Some of them are likely to follow through on that, some aren't. So, but that's helpful to know in advance, or, you know, so you know how to follow up with it. This one's a little strange, but I want to mention it because it comes up a lot. I think that sometimes people on the spectrum have a different sense of time. So specifically, they loathe boredom. Like, bored is the worst thing in the world for them. So if you're having a conversation and they say, how many more minutes? And, you know, like the parent says 15, 20. That's not going to work. Like, that's way too long sometimes. So again, you have to stop and address the boredom and the time. Otherwise, it's not going to be a functional 20 minutes. On the other hand, it can go the other way, where like they come in, they start talking about something, 50 minutes goes by, and you say, well, we're out of time. And they say, but I had 4 things I wanted to talk about. Yeah. So time is very important, and, you know, discussing what we're going to do during our time, using a visual timer, you know, anything we can do where we are kind of joining them and sharing their point on his perspective on time. So I want to acknowledge that, again, we've identified a problem and we're throwing it back on the consumer and the family to fix it. I admit that we're doing that. And, you know, there are often situations where someone either can't do it themselves or they don't have someone who can do it for them. Nonetheless, I think there are many cases where a competent clinician can be successful if we give them this kind of support. On the other hand, sometimes they can't. And, you know, I think like Hugh said, if you can figure out what your core needs are, communicate them to the person. If they can't adjust to those, you're probably going to just cut your losses and move on. Because typically, you know, people on the spectrum cannot compromise on their core needs. So it's not going to be successful. It isn't always the clinician's responsibility to meet your needs, because obviously they're human beings and they live under constraints like you do. But, you know, if they're not able to, it's probably good to figure that out and move on. For some reason, I always remember years ago, I took over a case from a retiring colleague, and when I first met the client, she said, I live on the west side of Madison and work on the west side, and she said, so my old clinician would meet us at the Perkins, the East Side Perkins, at 8 a.m. on Monday morning. Can you do that? I was like, no, I can't do that. That will take 3 hours and is not billable. So we're not, you know, they're not always going to be able to meet your needs, but if they can't, you probably want to move on. If your treatment fails, you want to try a different provider. You might want to try a different modality, like maybe art therapy or something different. And sometimes you might have to wait for a different window of development. So you don't have to give up, and you don't have to take it personally. A lot of psychotherapy and mental health treatment fails. So the last statistic I heard was that the modal number of psychotherapy visits is 5 visits, which means that half of all courses of treatment are shorter than 5 visits. Right? So very often it fails, and it fails for reasons that aren't related to autism. It could be chemistry. It could be as we've talked about, sort of the lack of bang for your buck. If you have to travel a long way, if your treatment's expensive. So there's reasons why it just might not succeed. But if it doesn't, you probably want to keep looking. So I came up with a couple discussion questions. Should I throw those out now? Yeah, okay. Okay. So my questions for you to discuss are, so what does autism-informed mental health treatment mean for you and your community and in your many of us support a particular person or persons. So are there situations where just a competent generalist is good enough and is useful? Or is that really not true? How does the combination of ASD, DD, and a mental illness change the treatment for the mental illness? So, autism plus anxiety, does that equal anxiety? Like a horse plus a horse equals a horse? Or is it autism plus anxiety produces something different, like a horse plus a donkey equals a mule? Are they the same really, and are they treated the same, or are they not? All right. Thank you very much.